everyone, welcome. We're so happy to see everyone here this morning. So we're opening up the morning talking about the care that we provide over at the OB Motivate Clinic, which is with the VCU Health System, where we provide co-located care for pregnant and parenting women with substance use disorders. And so today, what we're going to be doing is going through a lot of evidence-based treatments and the evidence base behind our care model and the things that we provide. And so that's kind of be the theme of our presentation this morning, and we will definitely have time for questions at the end. So my name is Caitlin Martin. I am an OBGYN and addiction medicine physician. I'm boarded in both. This is what I do. I love my job. I'm also a researcher, so I do a lot of research about addiction treatments and how we can make them better for people by tailoring them to individuals' needs, such as during the pregnancy and postpartum period.
I'm Kalie Owen. I'm a licensed clinical social worker from VCU. I'm also a certified substance abuse counselor. I am the dedicated social worker on the interdisciplinary team we have at OB Motivate, which we'll talk about more. Prior to coming to VCU, I was at a local methadone clinic as a counselor, and then many years ago, it feels like now, I was also trained and practiced briefly as a doula. So this is kind of melding those two lives for me, the pregnancy and doula care, and then also the substance abuse care as well.
Okay, great. So these are our presentation goals for today. Like I said, the basis of the presentation today is for us to talk about our OB Motivate model, which is an evidence-based care model that we provide over at VCU Health. But however, in doing so, we're going to be going through the evidence base that goes behind all the treatment modalities that we provide, as well as a little bit of numbers, some epidemiology, something about medications. I will talk about medications, so hold with me. I won't go through too much neurobiology or pharmacology. And please write down questions that you have throughout, and we will definitely take them at the end. So we don't have to go through what addiction is and what a substance use disorder is, but this is a definition that we use to kind of mold how we perform our services over at OB Motivate, thinking about the chronic disease model. And this is the definition that is a little excerpt from the definition from the American Society of Addiction Medicine, which is the professional society that I have as an addiction medicine physician that I go by. And why this is important, why we start with something that you guys already all know, is that historically, addiction care, substance use disorder treatments have been siloed from the health system. They've kind of been in their own little space away from the traditional medical system that we think of. But over the years, we're moving towards bringing a more public health approach to the treatment of substance use disorders. And really, this has really been happening, I think, over the tenure of my career so far. And so what we do is so unique in that we have integrated substance use disorder treatments for a priority population into the walls of a health system that sometimes has some rigid silos, maybe like things are only done a quote certain way, but we might need to do things maybe a little bit of a different way. And so that is the basis of what we'll be talking about today, is the integration of evidence-based substance use disorder treatments for pregnant and parenting women within the traditional silos of the healthcare system. And so it's not really anything new for everyone to know, but overdoses continue to be a leading cause of mortality in our country. And unfortunately, we're seeing that this trend is continuing during the periods of pregnancy and postpartum. So I want you to kind of put your hats on when you're thinking about pregnancy and postpartum. I would say during our session and throughout the rest of today too, where we have multiple perinatal sessions, thinking about pregnancy and postpartum are two periods of the life course that are going to affect 50%, up to 50% of our population today, right? So a person that is pregnant is still a person first. They just happen to be pregnant for about 9 months, right? And then to be postpartum for about 12 months of their life course. And so there's this misperception I see a lot where people say, well, that person's pregnant, they should just stop using drugs, or their blood pressure problem, but we don't say their blood pressure problem should just go away when they become pregnant, right? There's this misperception that pregnant people are more defined by the pregnancy than by being a person first. And so I want you to think of pregnancy and postpartum as the periods of the life course. And that's why we continue to see that the maternal mortality crisis that's been happening in our country over the last few last decade or so especially has gotten worse, really has intersected with the overdose crisis. Again, not surprising given that overdoses have continued to be a leading cause of death, and so therefore it's not surprising that overdoses are a leading cause of mortality during the periods of pregnancy and especially that 1 year postpartum period. And so put your hats on thinking about pregnancy and postpartum as periods in the life course that affect women in our country. And so thinking about substance use during the perinatal period, again, there's just to remind people that the most commonly used substances are alcohol, nicotine, and cannabis by all people, including during the periods of pregnancy and postpartum. It kind of hurts my little soul when my residents and med students come through the clinic and I teach them, everything about Suboxone and buprenorphine and all the things, and then they walk away and I say, and they'll tell someone else that, opioid use disorder is the most common substance use disorder. And I'm like, no, it's not. It's alcohol. And so just remember that today we're going to be talking a little bit more about opioids, just because our patient population that we have at OB Motivate, a lot of them self-select to come to us because we do prescribe buprenorphine, and we do, at the health system, we do have added specialty in treating infants with neonatal opioid withdrawal syndrome. So a lot of patients kind of come to us kind of hearing about that. But please don't forget that the same substance use disorders that are quite prevalent in all people continue to be the same prevalence generally during the periods of pregnancy and postpartum. And then again, this is not anything that people don't know, that we'd use the DSM-5 to diagnose someone with a substance use disorder, but I'm putting this up here again to remind you that when we're talking about our OB Motivate model and the evidence-based care that we provide, again, we're doing it within the walls of a health system, within the medical system. So when you come to me, because I'm an addiction medicine physician, I'm gonna, take a history, do a physical exam, talk about your medical history, all the things. But what I have to end up doing is I have to go into the chart, right? And I have to go through the DSM-5 criteria. I have to take your life story that you just gave me, even though you just met me, and then I have to put it into little checky boxes to say what level of a DSM-5 diagnosis do you have. But that is how we operate. That is how we integrate care for addiction into the health system, is by using these models, the ways that we have to work in the health system. And so this is just one example of what we have to do, is just thinking about the DSM-5 criteria when someone's coming to us for treatment. So when we go, Kalie and I talk to a lot of audiences about perinatal addiction, and people always are asking us, what are some things I can do to take back to my health system? We talk to a lot of nurses and social workers, physicians and other providers who are seeing people in the context of maybe women's health care, or maybe in the context of primary care, right? Pediatrics, et cetera. And so we always get the questions about screenings. So just so you know, the evidence-based recommendations by many professional societies is that screening for a substance use disorder for all people, including during the periods of pregnancy and postpartum, should be done using a validated verbal screening tool. I gave you 2 examples that we personally like up on the screen, but there's many more that are available on the NIDA website. And it's not with drug testing. Drug testing is not a validated screening tool for a substance use disorder. So I don't really have to emphasize that in this audience, but a lot of the audiences that we talk to, this is a huge thing. There's this big misperception out there that, I should be drug testing every pregnant person that comes through because I need to make sure I know if they're using drugs and I need to catch them in order to help the baby. There's been lots of evidence to show that actually drug testing, especially when it's done universally or it's not done as indicated, it's not done in order to manage your medical decision making, that it actually causes harm to the family. And we personally, unfortunately, have seen a lot of that harm done to our patients and to our patients' families over the years. And it's not surprising to this audience, right? Because drug testing will tell me like, did someone use cocaine within the last 3 days? Okay, that's great. Sure, maybe I need to know that, but I probably don't need to know that. But knowing if someone used cocaine in the last 3 days, as my example, is not going to give me the life story that I need to fill out the checky boxes on the prior slide, right, of the DSM-5 criteria. So when we talk about screening in the healthcare field, screening is a way for me to see, are you a high, medium, or low risk for a condition that I need to further assess, to give you the diagnosis, to put it in your medical chart in order for me to bill, in order for me to prescribe you medications, et cetera. Knowing if someone used drugs in the last couple of days isn't going to do anything. So We get that a lot, and sometimes for some reason people think, well, they have there's a lot of stigma and discrimination associated with pregnancy and parenting on top of substance use. And so even though people might know this in a non-pregnant population, sometimes those implicit biases come out and people think, well, I should be doing something different because they're pregnant. And that is not true. So a couple, the screeners I put on the prior slide are those kind of comprehensive for drug and alcohol use. There's many screeners that are recommended in the general healthcare setting for alcohol use. I just put one up here, the Audit C. This is the one that generally will recommend. It has been validated in pregnancy too and seemed to be quite good. So these are just some examples. If you are working in a space where you're thinking about incorporating them, feel free to take a picture of the slide. And so going on a little bit about opioid use disorder. So a lot of all the care that we provide for opioid use disorder generally is based in this document. So if you need one document that you want to take home and bring to your to others that you're working with, this is a document that is published by SAMHSA multiple years ago. However, this is considered our standard of care. So in the healthcare setting, we will say things like the gold standard or the standard of care. Generally, that's going to refer to publications that have been published by national organizations, professional societies that say, this is the appropriate treatment, this is the appropriate assessment that you should do for this disease or this condition. And so this SAMHSA publication on opioid use disorder is considered our standard of care. So if you need a resource to go to, anything medical related, related to opioid use disorder and pregnancy, this is what I recommend. These are some of the take-home points from a very long document. It's like over 200 pages or something, but some of the take-home bullet points that we brought it to you. Number one, I would say, is medications for opioid use disorder, such as buprenorphine or methadone, are recommended for all people, including during the periods of pregnancy and postpartum, and should be continued throughout the periods of pregnancy and postpartum if they are part of the treatment plan that is benefiting the patient in front of you. Hands down. So there's a lot of people that think like, oh, I need to come off my medicine, it's bad for my baby. Nope. It's actually, the evidence is very clear that women who continue their medications through pregnancy and postpartum have better outcomes, not just for themselves, but for their families. And so that has lots of evidence base that's published in this publication too. And so buprenorphine and methadone are both evidence-based treatments for opioid use disorder and pregnancy. A lot of people ask me like, well, which one's, quote, better? There's not one that's better. The better one is the better one for that patient, right? It's the one that works for the patient in front of you. I'm a gynecologist, so I kind of think of it like birth control, right? We have pills, we have patches, we have IUDs, we have things you put in your arm. We have a whole bunch of options. Now, maybe one is a little bit more efficacious, right, based on the research, right, that I learned as an OBGYN, but it's not going to be efficacious if my patient in front of me doesn't use it. They go to another provider down the street and switch to something else, right? So the best option, the best medication is the one that works for the patient in front of you. And there are some slight differences in some of the neonatal effects, and I think that's some of what comes out and people saying that there is one that's better than the other, and Kalie's going to be going over that later in the presentation. So again, these are the medications that we have that are FDA approved for the treatment of opioid use disorder in all people, and we do recommend them in pregnancy and postpartum too. So buprenorphine is the active ingredient that's in Suboxone. So Suboxone is buprenorphine naloxone. It's a combination of the two. The naloxone is only there as a deterrent. It's not bioavailable when people take it sublingually. In other words, rather than the medical lingo, is that if a patient is taking the Suboxone film under the tongue, taking it as prescribed, that naloxone component isn't doing anything, okay? So a lot of patients will come and say, well, I don't want to take that Suboxone because it has that blocker in it. Well, true, it does have the naloxone component, but if they're taking it as prescribed, it's not doing anything. It's not bioavailable. It's not actually acting on anything in the body. Back in the day, we used to think that patients during pregnancy could only use the buprenorphine mono tablets, so the straight buprenorphine without the naloxone component, also called Subutex. That actually nowadays, and the reason why, I'll tell you why, is that the only clinical trial that we've had it was published in 2010 that looked at buprenorphine versus methadone. It was called the Mother trial. and it looked at the outcomes for the moms and babies when they were randomized. So kind of flipping of a coin, and half of the people got buprenorphine tablets and the other half got methadone for the treatment of opioid use disorder during pregnancy. At that time, back in the day, they used the buprenorphine tablets. And like everything else in obstetrics, we do one clinical trial and we keep doing it for decades and just keep doing it because it's so hard to do really good research in pregnant people. I can attest to that because of all the ethical and legal and regulatory concerns. So we just kept doing it. However, since then, there's been copious additional research outside of the clinical trial space that shows that Suboxone, so buprenorphine, naloxone, that combination, actually is safe in pregnancy and breastfeeding. So now the recommendations have changed. And so some people just have, we see sometimes that community providers are still switching people. And so we're just letting you know the recommendations have changed by SAMHSA also, that Suboxone, the buprenorphine, naloxone, is what we recommend in pregnancy and breastfeeding versus back in the day. You might be interested in the extended release options of buprenorphine, like Sublocade and Brixadi. There actually is very recent emerging evidence. Actually, even a clinical trial recently, looking at weekly Brixadi at least, showing that both of those, we nowadays will say that those are also safe too. I would recommend that if you are a prescriber and you are seeing patients during pregnancy who might be on extended release, come talk to me, because there just is some special counseling that those patients need about the risks and benefits of the medication, but we continue those medications in pregnancy if someone is receiving benefit from those medications during pregnancy. And then I already talked about methadone as evidence-based treatment. It's been around for a while. Naltrexone or Vivitrol, that one we don't have as much data for, but kind of like the injectable forms of buprenorphine, we're finding that there's a lot more observational data, so research that's not a clinical trial, but we're seeing more and more research and we compile it together. We're not seeing any proven evidence, any consistent evidence of proven fetal harm. So there's no consistent evidence of proven fetal harm for any of these medications, including naltrexone. So if I have a patient who is on naltrexone, I will continue it. I will say that a lot of patients, sometimes the naltrexone doesn't work as well as the stressors of pregnancy increase throughout pregnancy and postpartum. So a lot of the patients I personally have had in my practice who were on naltrexone, a lot of them ended up switching to buprenorphine later in pregnancy, just because, it's just a lot. Pregnancy and postpartum is a lot, and these patients wanted to be very proactive about their treatment and their recovery. Well, that's just a little clinical anecdote that I have. My job is to talk about medications. This is what I do. So it's the role I play on our large team. So we also have FDA-approved medications for alcohol use disorder that are FDA-approved for all people that are severely underutilized in this country in the general population. There's been some data on kind of a population level, so looking at big groups of people across the country, and I found that only 3% of people with alcohol use disorder are receiving medications for alcohol use disorder. Now, does every person who has alcohol use disorder need a medication? No, but I'm pretty sure there's probably more than 3% that might get some type of benefit from them, at least for a period of the course of their treatment and recovery. And so we have a long way to go at medications for alcohol use disorder. I talk to a lot of prescribers and providers across different specialties, and most people don't even know that we have these. So that's a whole nother topic. But during pregnancy and postpartum, we have 0 clinical trials that have been done with these medications in pregnancy and breastfeeding. However, we do have some of that observational data that we've pieced together. And last year, we created the first provider-facing training that is currently the only stated standard of care that we have from a medical standpoint on medications for alcohol use disorder that are on the PCSS website. If you are a prescriber and you need your 8 hours for your DEA renewal, the PCSS websites are excellent. They're free online modules. If you know anyone in your practice who wants to learn a little bit more about medications for opioid and alcohol use disorder, highly recommend the PCSS website because it's backed by SAMHSA and a lot of federal funding. So it goes along with those kind of standard of care publications that I started to talk to you about. And so this is the take-home point from the modules that we created about medications for alcohol use disorder for pregnant people and also people people who are breastfeeding. And so in general, we are now saying that acamprosate and naltrexone should be considered as a part of the treatment plan for patients with alcohol use disorder during pregnancy and breastfeeding. We do recommend that. Disulfiram or antabuse, we do not recommend because there are some stated potential teratogenic effects or risk of congenital defects in the fetus. So not that one, but the other two we do recommend, and we say that they're safe during pregnancy and breastfeeding. And so as I kind of round out my portion of the talk, I just want to, in our clinic, I talked a lot about medications, I talked about treatments, but we recognize that not all patients are going to want to do that full treatment plan, right? Or patients are working on their treatment, but it's a process. And so we definitely incorporate harm reduction approaches into everything we do at the OB Motivate Clinic, and we tailor that to the needs of the patient in front of us. And I will tell you that this is also evidence-based. There's some obviously controversy about that in the federal funding space right now. If you work in that, but I can tell you as a researcher that our harm reduction strategies are an evidence-based way to help people be healthy on the course of their addiction and recovery. And so when we are seeing people in our clinic, and especially when we have any trainees, I would say, that come through a clinic, we get med students and fellows and social work interns, et cetera. If you want one thing to take away today, no matter what role you're playing in what you do, we all could be probably a little bit better, unless you're like really good, at using person-first language as it pertains to substance use disorders for people during pregnancy and postpartum. And we're talking about the dyads and the mother-baby dyad. When you are working in your in a professional role. So especially for those of us who are medical providers, again, we're focusing on integrating substance use treatment into the medical space. We really, really push this with everyone who works with us, is that saying that baby is not being born addicted, that baby is being born exposed to a substance in utero. Do you see the difference? Right? And so there's a couple options. So if you go to the Words Matter on NIDAMED, you just Google it. There's two documents. There's one that's general for substance use disorder, person-first language, that's tailored to healthcare providers. And there's actually an additional document specific to pregnancy, postpartum, and family care that we really love that exists. So if you need a resource to take back to bring to the other people that work with you, or maybe you are teaching others, maybe some people who are going through internships, this is a document that we require all of our interns to work through.
Yeah, and so we talked a lot about what we do during pregnancy, but then it's also really important to talk about postpartum planning. As soon as a patient comes to us, we're talking, what is the postpartum period going to look like? Because we know that it can be really difficult for some people. There's a lot of emotions, you have a baby, there's a lot of things that can happen, so we start that conversation early. One thing that our patients are really concerned about is pain management. If you have a C-section, and I'm on Suboxone, am I going to be able to take any pain medication for my major abdominal surgery? If I ask for pain medication, is the hospital going to think, oh my God, they're going to think I'm just drug seeking, I'm going to ask for more pain medication? But research shows that untreated pain is actually a higher risk for relapse than treating the pain appropriately. And yes, a person stable on Suboxone or any buprenorphine can safely take an opiate. They are not going to go into withdrawal. So we always talk about pain management. We offer a consultation with an anesthesiologist before they deliver, so they can ask all those questions and get those answered. We talk about birth control. We don't want patients to get pregnant too soon after their pregnancy. Your body and your mind need time to heal, recommended at least 18 months. So we always discuss with patients what they would like to do postpartum. Postpartum mood and anxiety disorders, this population has a higher risk of developing a mood disorder if you have a history of trauma, if you have a history of substance use. So we're planning now, and those symptoms can also pop up during your pregnancy. They don't have, postpartum. Actually, they don't always show up postpartum. They can show up during the pregnancy as well. So we have a validated screening tool called the EPDS that we do at every single visit so that we can track a patient's mood, anxiety, and depression and thoughts of self-harm and react really quickly connect them to resources. If they want to start medication, have those conversations, referrals to psychiatry, referrals to counseling, referrals to groups, things like that. I'll talk a little bit more about the Child Protective Service aspect, but we do bring that up early and often. That's that anxiety and fear of interacting with their child welfare system is one of the things that keeps pregnant women from engaging in treatment. It keeps pregnant women from being open and honest about the help that they need, which then keeps them from getting the help that they need to have a strong, safe family and a safe pregnancy. And then we always counsel them about continuing their medication for their opiate use disorder if it's working, and also educating them that their dose may need to change during pregnancy as the physiology of your body is changing, your metabolism is changing, the way that you process medication changes. So sometimes people are like, I've been at 100 milligrams of methadone forever, but now I'm feeling withdrawal symptoms. We don't want you to feel withdrawal symptoms because if you're feeling withdrawal symptoms, baby's feeling withdrawal symptoms. And you also have that risk of relapse. So we want to educate patients that sometimes temporarily your dose may need to go up during pregnancy, especially throughout the pregnancy, and then probably soon thereafter you deliver, it can come back down to your previous dose. So this is our clinic at VCU Health, the OB Motivate Clinic. We are an outpatient clinic, so we are not a residential program. We are co-located, meaning a patient comes to their prenatal appointment, and they are sitting in that exam room just like any other pregnant patient at VCU Health, and they'll see an OBGYN. They will see an addiction medicine doctor. They'll see an RN who has specialized training in addiction. They'll see a social worker. We now have peer recovery specialists at VCU they can see. So the patient comes to one appointment and we kind of bring all the specialists to them to make it as easy as possible. A lot of our patients don't even live in the Richmond area. We have several patients from almost to North Carolina, South Boston, Halifax, those areas, because they can't find providers that are doing this co-located treatment like we are, and they're willing to drive 2 hours, take Medicaid transportation 2.5 hours to get to us so that they can have this care. We don't want them coming back and forth multiple times a week. Oh, on Monday you see your OBGYN, on Tuesday you see your addiction doctor. No, our appointments are a little long, but you're gonna sit there, we'll have snacks, we have water, we will make you as comfortable as possible. A lot of people are very concerned. We talked about treating pregnant mom. What is happening to baby when I'm taking these medications? So there's NAS and there's NOWS. So neonatal abstinence syndrome is kind of those withdrawal symptoms that baby can have. And the reason that we separate it into NAS and NOWS is because a baby can have withdrawal symptoms for lots of medications that patients take. A baby can have withdrawal symptoms from your Zoloft, just as you can have withdrawal symptoms when you come off an SSRI. It doesn't mean that there's long-term harm happening to baby. It's just something that is known and very treatable and temporary. So when we talk about NOWS, that's when we're getting really specific to those opiate withdrawal symptoms. And we'll talk a little bit about what those look like. So if a baby is chronically, over time, exposed to these medications that are prescribed and that are safe, just as we would become kind of physically dependent upon those, the baby is also becoming a bit physically dependent upon those. And some babies need treatment or interventions afterwards, and some don't. Just like it could be different if I quickly came off a medication versus if you quickly came off a medication, and we could have different experiences with that. It's temporary, it's expected, and there's no proven long-term harm to these withdrawal symptoms. A lot of patients will come in, they've been stable on their Suboxone, they're stable on their methadone, they're like, I want to come off of everything because I don't want to hurt my baby. And so we counsel them, obviously it's their choice whether or not they come off of their medications. It's not the recommended science because of the risk of relapse and return to use. So counseling patients on the safety and efficacy of these medications is really, really important. And obviously we always leave space for their concerns and their autonomy. We said it before, it's so worth saying again, A baby cannot be born addicted. We talked about the DSM and the criteria for being diagnosed with a substance use disorder. You have to continuously do an action that you know will cause harm in order to be diagnosed with an addiction. A baby cannot do that. A baby cannot be addicted. They just have that physical dependency. And that dependency can happen with oxy. It can happen with heroin, with buprenorphine, or with methadone. So these are some of those symptoms that babies can have. Again, not every baby will have guaranteed symptoms of withdrawal, but these are some of the things that are possible to see. So starting at the top, you have yawning, sneezing, runny nose. They can have jitters and kind of tighten their muscles a little bit, diarrhea, difficulty gaining weight, shallow, quick breaths, poor feeding, and then just feeling really overstimulated. So we know that those can happen. So when a pregnant person is on any of these medications and when they deliver, they're not going to be discharged for at least, the baby's not going to be discharged for at least 4 days. So during that 4 days is when you're going to see whether or not baby's going to have those withdrawal symptoms, because it might not be the first day or two. So once those 4 days happen, then you kind of know what the severity is going to be and what kind of treatment baby will need. 50 to 80% of newborns will develop some symptoms of withdrawal. It doesn't mean it's going to be all of those symptoms. It doesn't say the severity of those symptoms, but there may be some. And that also includes babies exposed to the buprenorphine, the Suboxone, and the methadone. We always counsel patients that those rates go up if there's polysubstance use. So if you're taking your Suboxone and you're also using nicotine, the rates of withdrawal symptoms are going to go up. If you're on methadone and then also have a prescription for a benzodiazepine like Xanax, those symptoms are going to go up because of the interaction. And baby can have withdrawal symptoms from nicotine too, just as as adults can. So we always counsel patients, really try to get off nicotine and reduce that polysubstance exposure. And then yes, they're monitored. So we don't know, we can't predict kind of which babies are definitely gonna have symptoms of withdrawal. Just like I can take a medication and it doesn't make me feel good, someone else can take it and it feels perfect for them. It's based a lot on genetics. So older babies, so babies that go 40 weeks or more tend to have a little bit more withdrawal symptoms than babies that come a little bit earlier. Bigger babies tend to have more withdrawal symptoms. Boy babies tend to have more withdrawal symptoms. It's really based on like the genetics of baby. It's not dose dependent, meaning if I'm on 20 milligrams of Suboxone versus 30, that's not really gonna be the determining factor. So a lot of patients are like, I don't wanna go up because I don't wanna increase the risk of withdrawal symptoms. That's not what's gonna determine if baby has withdrawal symptoms or not. It's so important to be on the safest, most comfortable dose for that pregnant person. And then the withdrawal symptoms are gonna come if they're gonna come. And then we also talk a lot about the care environment after birth. So if baby's really jittery, having trouble resting, having trouble eating, we want a dark, we want a warm, we want a quiet, we want a calm environment for baby, and that's gonna really help with some of those symptoms as well. Again, withdrawal symptoms are expected and treatable. We know that this is a possibility, but as with counseling, it is worth the risk. And it doesn't relate to dose. So we know that mom going through withdrawal symptoms during pregnancy, that can cause stress on baby. So that can cause known harm. So we wanna make sure that the dose is going up appropriately so that the pregnant person is not experiencing those withdrawal symptoms during pregnancy. And as we saw earlier, based on the SAMHSA guidance, a medical withdrawal during pregnancy is not the recommended treatment for any substance use disorder because it can cause a lot of stress on baby. So our hospital uses Eat, Sleep, Console in order to determine kind of what the care for baby is going to be. So how is baby eating? How is baby sleeping? Is baby consolable? So by determining those factors, we'll see, does baby just need the calm environment? Does baby maybe need to go to the NICU and get like a methadone treatment? So sometimes a baby will be started on an opiate and then slowly tapered off, just like a person would be slowly tapered off in order to manage those withdrawal symptoms safely. We do that at VCU very well. Not every hospital system does, so sometimes we will get babies from other hospital systems because we do have this treatment protocol. Toxicology testing. So as we talked about earlier, we do not believe in universal drug screens for all patients, drug testing. The adult woman, you have to have her consent if you want to drug test her in the hospital setting or in the doctor's office. That consent is not legally required for the infant. It is always recommended that you discuss it with the parent and get them to agree to that testing, but legally it is not required. So sometimes baby will be drug tested if they're having some symptoms so that a doctor can know what their treatment options should be. Of course, then we get into the legality of CPS, and then now if baby tests positive for a substance, that can now be reportable. And that is true, and that is a fear that people have. And we'll talk a little bit more about CPS. And then there's a lot of other sessions today about the child welfare system as well. So this is just some of that treatment for withdrawal symptoms. We want to keep parent and caregivers in the room with baby to provide that constant soothing, to provide the skin-to-skin contact, breastfeeding when appropriate. It is appropriate when taking the medications that we talked about earlier, like methadone, buprenorphine. A very, very small amount gets through the milk. Mostly it's just that skin-to-skin contact that's really helpful for baby. Obviously there are, if a person's continuing to use illicit substances, we're not recommending breastfeeding, or if they have certain transmittable conditions, we'll counsel them on when it is safe. Swaddling, pacifier, and then sometimes the medications are appropriate. More often than not, most of the babies we see do not get to the point of NICU and needing medications for treating their withdrawal symptoms. Sometimes it's just the nursery rooming in with parents and then having all of that skin-to-skin contact and care. Breastfeeding benefits, of course. Not every person can breastfeed, but there are lots of benefits. It can reduce the severity of the withdrawal symptoms and reduce length of stay of hospitalization. And again, very little bit is getting through the breast milk, but it sometimes can be enough to kind of ease those withdrawal symptoms. Any adverse consequence to babies, we're not seeing that from the substance use itself or from the medications itself. It's more a combination of socioeconomic factors, stress factors, trauma factors, environment, genetics. I say that for opiate use disorder. I was just sent an article about alcohol and fetal alcohol syndrome disorder, which we don't really talk about in this. The harm from alcohol is generally not seen in that 4-day window. So the 4-day window, we're looking for the withdrawal symptoms from opiates. Alcohol use disorder and alcohol use in general, those harms are generally seen later in life when you start to have maybe developmental delays or behavioral problems in school, concentration and things like that. So the medications are not what's causing that harm. And the children who have the greatest potential for success have parents and caregivers who are adequately treated for these chronic conditions and who feel supported and who get education. We have parenting classes through VCU and the community at large, and having that kind of social support is really what grows these strong families. So there can be legal consequences for substance use during pregnancy, and it varies drastically depending on what state you live in. There are several states that criminalize it. Women can be, not in Virginia, anecdotally, yes, but as it's written, women in Virginia are not incarcerated during their pregnancy purely for using illicit substances. There are states where you can be, Minnesota, South Dakota, Wisconsin, allow that if you're using an illicit substance during pregnancy, even if you were using that same substance and if you weren't pregnant, that wouldn't be get jail time. Because of the pregnancy, we're gonna put you in jail because we're gonna control the environment. Even though we work with the jails, they're not providing adequate environments for pregnant people. Maybe sometimes they can keep people from using illicit substances, but that's not where people are getting the best care. In Virginia, we are required to report substance use, including medications like methadone and Suboxone, if baby is affected by those substances. And they are intentionally vague. They use that word affected because there's no real definition for that. So at a lot of hospital systems, any substance exposure is going to be a report to CPS. And just because there's a report made to that local CPS doesn't necessarily mean a case is going to be opened. So if we have a patient hasn't used illicit substances in 5 years, only taking their Suboxone, they deliver, baby has withdrawal symptoms, all that information is reported to CPS. CPS may be like, oh, we're not going to open that case. So just because it has to be reported doesn't 100% guarantee that a case is going to be opened, or they're going to interview the family or drug test the family or anything like that. The issue is we don't know what's going to happen. Sometimes CPS does open a case for a family like that because they want to make sure that that family has the supports in place that they need for that postpartum period. Very rarely does CPS come to the hospital and do a removal and take a child into foster care unless the social situation is extremely unsafe. CPS also is very segmented. So Richmond CPS is kind of autonomous from South Hill CPS or Mecklenburg CPS or, Fairfax CPS. So they all kind of have their way of doing things. So it puts me in a difficult position having these conversations with patients being like, okay, what county do you live in? Do you have a history with that county with CPS? Because all of those factors are kind of going to determine whether or not a case is open, even if a person has stability in their substance use disorder, or maybe they came into care at the beginning of their pregnancy, they had been using, and then they gained that stability. Because baby can test positive with what's called their meconium, that first poop that baby has. They can test positive for substances even if they were used all the way back at 12 weeks of pregnancy, and there's been no use since then. Not every hospital system uses that test. It's definitely not medically necessary. As we were saying, that's not giving us any good information about what's happening right now. But some hospital systems use that and report that and say baby tested positive for cocaine, even if there wasn't any cocaine for several months. So it gets a little messy, but we always talk about this with patients. We want to bring it up because patients already come in scared. Sometimes they have a history with CPS, or they have friends and family, or they themselves were in the foster care system. So we believe in discussing it as openly and honestly and as frequently as that patient desires. And then we can be a support for that patient postpartum as well. I talk to a lot of CPS workers, explain the medications. Not everybody is as educated about the medications, explain, substance use disorders, and kind of walk them through that as well. So my role is I assess a lot of the social determinants of health, because if we look at Maslow's hierarchy of needs, if a patient doesn't have their physiological needs of safety met, it's going to be really hard to be focusing on those higher needs of, processing things that have happened to them, kind of, working through therapy if you're living in your car and you're thinking about where am I going to eat. it's really hard to focus on those other higher learnings. So we do a lot of referrals to community resources. We work really closely with the local CSBs, local residential programs, other programs throughout the region to really get those needs met for patients. We discuss the nows with them and want to make sure that they're as educated as possible about the process. Briefly, so later today, there's actually a speaker named Stacy from R Street, which is a legal advocacy center that is now focusing a lot more of their activity in Virginia. So she will be able to speak about this a lot better than I can. Please stay for her talk as well. But this is just like a little bit of like how we got to where we are with the reporting rules and the CPS requirements. So it started in 1974. Federally, we had CAPTA. So we had federal funding for assessments, treatment, and prevention of substance use disorders. It was updated in 2016. We now have what we call a plan of safe care that's required for any substance-exposed infant, and that includes exposure to buprenorphine and methadone. So it's a document I create with patients. It's supposed to be a living document that houses all of the treatment that they're receiving. Are they having their mental health needs met? Do they have diapers and a crib and a car seat, pediatrician, doctor, just making sure that all of their needs are being met in order to just have the safest pregnancy possible, but then also the safest future possible for them. So the Virginia law, as I said, there's a lot of talk about updating this Virginia law to exclude things like Suboxone and methadone, because a lot of patients are like, I don't want to get on that medication because I'm on that medication. Now I'm reportable to CPS. And so it keeps people from accessing care. We know that the states that have the higher legal ramifications for substance use disorder, patients and babies are having worse outcomes. And it makes sense because you're not going to tell your doctor, I need help. I need help with my alcohol use disorder. I need help with my opiate use disorder. Because as soon as you say that in some states, that's immediately reportable legally and to CPS. You could get the custody of your current children taken away. You could get incarcerated. So we have women avoiding prenatal care. We have women avoiding substance use care. So we have worse outcomes for the pregnancy, lower birth weights, less access to treatment. So in Virginia, there's a big push to try to get away from all these mandates of reporting so that we aren't keeping women from accessing the care that they need, because we already know of the people who should be getting care, it's already underutilized. We don't need to set up any more barriers. So I think in the latest General Assembly, they're now going to create a work group. And so the work group's going to think about this and then hopefully report out with recommendations for our new governor. We've talked about this already, the perinatal mood and anxiety disorders. So this population has higher rates, so that's something we're always cognizant of and always checking in. You know, we don't have a woman deliver and say, cool, see you in 6 weeks. We do 1-week check-ins, 2-week check-ins virtually. How are you doing? How are you feeling? Do we need referrals to psychiatry? VCU has some wonderful perinatal psychiatrists, because you'll find not every psychiatrist in the community will treat pregnant women. Some places will say, oh, you're pregnant, get off all your meds. It's been working for you for years. I don't care. What about the baby? Well, what about the baby if I have my untreated anxiety and I can't leave the house, or my untreated depression and it's hard to even feed myself? What's happening to the baby then? So there's a lot of research happening on the safety and efficacy of mental health medications in pregnancy so that we can adequately treat pregnant women as well as we would treat any adult or child. We also do doula referrals. In Virginia, Medicaid is paying for doulas, and most of our patients are on Medicaid. So a doula is a trained birth professional who can provide education about the birth process, develop birth plans, and then be that physical and emotional support during a delivery as well. And we know all of the decreased rates of C-sections, decreased length of labor, more positive birth experience when you have a doula. So we have some good treatment options in Virginia, and especially in Richmond, but there are always barriers to all these options, especially for women especially for pregnant women. Some residential programs have restrictions on medications for opiate use disorder. Most do not allow children. We do, of course, have RBHA in the house. We saw them here represented. Yes, love RBHA. Thank you. We refer to them all the time. Feel like I have Madeline on speed dial. They allow women to be pregnant throughout pregnancy in their program. Some residential programs cut off at 24 weeks. They don't want to deal with the risk. RBHA will accept pregnant women through any part of their pregnancy. They will allow you to come back with baby, and you can have your other children, up to usually 3 children, up to age 11, with you. They'll make sure the kids get to school. They have on-site daycare, so you can go to the programming and get the help that you need, but still have your baby with you. That doesn't exist anywhere else that I know of. Yes, RBHA. All right, we do want to make sure we have time for questions. Oh my goodness, it's 9:49. Just know that just because a patient isn't getting the recommended level of care that you think they need is not because they are trying to be difficult. Because if they the only option they have is a residential program that doesn't allow children, who's going to take care of their children? Who's going to make sure that their apartment is there when they get out? So there's always barriers. We do also, I saw here today, McShin is here, Oxford House is here. They have recovery homes that allow women and children. There's just not enough. And often it's one child, and sometimes there's age barriers to how old the child can be. So yes, I say, like, we have RBHA, we have some recovery houses that accept women and children, but it is not enough. There's always a wait list. I don't know of any that are recovery houses for families. We have a transgender patient. He doesn't feel comfortable going to a women and children's home. So just because a patient isn't accessing care that you think they could benefit from doesn't mean that they don't want that care. It just may be inaccessible. Behavioral health modalities, these are all shown to be really effective for substance use disorder treatment and other treatment. Each of these, if you are a practitioner or provider or somebody seeing somebody specialized in these or taking additional training in any of these is really, really helpful. I wish I could talk about all of them. Barriers, we talked about judgment and shame, even if it's not there. Even patients sometimes are scared to talk to us, even though we're very welcoming. But they have been judged and they have been shamed in other practices and made to feel bad because of having a chronic condition. So if a patient has been treated poorly somewhere, it can really prevent them from getting care anywhere else. Photo IDs, try to go to a methadone clinic without an ID. So sometimes we print out their face sheets just from the hospital, hoping that a clinic or somewhere will accept them, because that's money and that's time. I'm going to briefly talk about the upcoming peer recovery specialist training. You can take a picture. I also have flyers, and it's open to people who are not just peers, but who could use this training about pregnancy and parenting families. Jan Brown, who is in the house, is going to be leading that. She's also speaking next, so stick around for her and ask her lots of questions about it. Space is limited, so register early. And then, we have flyers up here. And then some patient resources, findtreatment.gov, and then also the Never Use Alone hotline is wonderful as well. Okay. Want to make sure we had time for questions. Sorry, I raced through the end of that.
I had a question about, at your clinic, are you also treating pelvic health conditions in the postpartum population at all?
Do you mean hepatitis C, syphilis?
I'm talking pelvic health, prolapse, individuals that have...
Oh, pelvic health.
Yes.
I heard public health.
Yeah.
What word are we talking about? So what's cool about us is that we kind of plant ourselves, the OB Motivate program, into kind of 3 different locations. So we plant ourselves within the greater OBGYN clinics at VCU Health. We plant ourselves within the addiction medicine clinics, which are technically under psychiatry at VCU Health. And then we also partner with local jails. So we do not ourselves do a lot of GYN currently, just because of staffing. However, we work within a huge clinic with a gazillion providers who do that.
In one of our clinics, we do have maternal fetal medicine doctors, so they specialize in like the high-risk pregnancies, so our patients also have access to those OBGYNs as well.
Hello, how dangerous is drinking alcohol on methadone?
Very. You mean during pregnancy or in general? Very. Alcohol is a depressant. Methadone is a depressant. And if everything gets too depressed, you can stop breathing. Alcohol is not recommended in any form while on methadone. And no amount of alcohol is proven to be safe during pregnancy. None.
So thank you. First off, I did want to clarify and celebrate that the bill that was changing the wording around medications for opioid use disorder in pregnancy, requiring a referral to CPS, got passed and is signed.
Did she sign it?
She signed it. It will be enacted in January.
I love it. I love it. Thank you.
The one thing that you said that was absolutely jarring for me was the fact that folks have to come from all around maybe the state to get to where you are. Has there been any talk about maybe doing mobile things or transportation issues for folks? And the last question I have is about any involvement with like churches, other folks to help disseminate some of this information.
Thank you. I would love to have a mobile van. I know that there's a lot more activity happening in like the Roanoke area and Carillon. They have now like a recovery women's home. They have some really great providers out there. So there are some people that are developing these programs. Medicaid actually is pretty wonderful for getting people to us. And if I put in the request, they'll come from a little bit further than they would otherwise. But I would love to get a van and go out.
Yeah, so, we're only two people. So I think a big part of what Kalie and I feel passionate about is equipping others to do this. Like, you don't need to come to the big academic center for this care. It's all just providing the right thing, correct? So I just want to put a shout out for all of you who are here today to get this extra training. There is more training, like we talked about the peer training coming up. Just a shout out for any providers out there, the Virginia Perinatal Mental Health Access Program. So they have VMAP for moms now. It's literally you call a phone and you will get a physician consult from someone who knows about both addiction and mental health. So I am not a psychiatrist, but I call them a lot, for example, to get help. And so I think we might be one of the very only states maybe where the lead physician for the perinatal access program in our state is a psychiatrist who is boarded in addiction medicine. And treats pregnant people. So those types of programs do exist to equip others to rise to the occasion to provide this care. And so patients don't have to be traveling 2 hours to come to the big academic center. We're going to end here because of time, but we're going to stay up here to continue taking any questions. Thank you.